All right, obtaining medical history and vital signs, Chapter 12. So, what's the medical history? So, everyone has a medical history. So, it's anything previous medical condition, current medical conditions, anything the patient might be experiencing. Signs. So, signs are, we talk about signs and symptoms in EMS. Signs are something that we can see. So, pale skin, rapid pulse, opened wound to the chest, obviously, um, a rash, anything like that. A symptom is something that the patient is feeling. So chest pain is a symptom, nausea, um, feeling dizzy or lightheaded, something we can't see as providers, but they can tell us that they're feeling is a symptom. So when we interview the patient, obviously the best source of information is the patient themselves, if they're alert and oriented. Um, we need to find out what their chief complaint is. Make sure your questions are clear. But make sure you give them time to respond as well. Don't just jump on like, do you have any medical history? Do you have any, do you take any medications? Give them time to answer. Listen carefully and document important details. I start every assessment pretty much the same way by saying, "Hey, I'm Ian. We're here to we're here to help you out today. Can you tell me your name?" And then they tell me their name. Can I get your last name? Sometimes I'll ask them to spell it for my partner who's doing documentation, and then I ask for their birthday, and then I say, okay, so how old does that make you? And then, so what brought us here today? Why did you call us today? To find out the chief complaint. SAMPLE is an acronym that kind of helps us do an assessment. So S is for signs and symptoms, A for allergies, M for medications, P for past pertinent medical history, L for last oral intake, and E events leading up to the illness or injury. So we've already talked about signs and symptoms. And then we ask them, are you allergic to any medications? And are you allergic to anything else besides medications? When they do say they're allergic to medications, if it's a medication that we might give them, like aspirin or morphine or fentanyl or something like that, ask them, well, what does that do to you? If they say, oh, it gives me hives and a rash, then that's a real allergy. Sometimes I've had patients say, well, morphine makes me sleepy. Well, that's not a real allergy. That's what morphine actually does. So make sure you clarify that with your patients. Medications. A lot of people ask if they have any medical history or medical problems first, but a lot of times people don't consider it a medical problem if they take medication for it. They think, well, it's not a problem anymore. I take medicine. So I always ask, do you take medications for anything before I ask for history? And then I say, they might say, well, I take lisinopril. And I'm like, oh, okay, so do you have a history of hypertension? And they say, yeah. I take warfarin. Oh, okay, so why are you on a blood thinner? And that kind of helps you get their history out of them, because they may forget. I mean, especially the elderly may have a lot of medical history and they may not just be able to ramble it all off. So if you can see their medications or just have them tell you what they are and then figure out why they take that. And don't be afraid to ask them too, like if you've never heard of the medication. So what do you take this for? Um, Sometimes that leads you to so after pertinent medical history, last oral intake, that's important in case the patient has to have surgery for anything, or maybe it's an allergic reaction, figuring out like what would you eat last. If you do think it's an allergic reaction, a follow-up question would be, have you ever eaten that before? Have you ever eaten there before? Did you eat anything you'd never eaten before in that meal? Things like that. And then the events leading to the illness or injury are, questions like, so what were you doing when this started? And were you just sitting on the couch? Were you out doing something strenuous? You kind of have to play detective for a minute. The OPQRST acronym is a way to test or to determine pain. It's very useful for chest pain. So you have onset, provocation, quality, region or radiate, severity, and time. So let's talk about each of these individually, because a lot of people get onset and time mixed up. So the onset is basically like similar to the E in sample. It's like, what were you doing when it started? Provocation is what makes it better or worse. And then your quality is like when you ask them to describe it for you, can you describe it for me? And then they might say, well, it's a sharp pain, or it's a dull pain, it's a pressure, things like that. And then ask, does the pain radiate anywhere? And they might say, oh, it radiates into my jaw or my left arm or whatever it might be. And then severity is when we rate it on a scale of 1 to 10. And then time, the difference between time and onset is what time did this start? Okay, so how long has it been going on? So it started at half an hour ago. And onset would be, so what were you doing when it started? Additional sources of information. So family members, they can be a great source of information. Not all the time, but for the most part they are. Bystanders, first responders, medical identification jewelry. So look for bracelets that might say they're diabetic or epileptic, things like that. Don't be afraid, like if you're in a public place, just ask the bystanders around you, just say, does anybody know them? Because maybe their friend is just kind of scared, doesn't want to talk, or doesn't even think to tell you things. So don't be afraid to ask that. Vital signs. So vital signs, respirations. Well, how many times do they breathe in a minute? Pulse, how many times do they beat in a minute? Their blood pressure, skin signs, color, temperature, condition, basically. Pupils, how big or small they are, and then perfusion. Are they getting the blood pumped around the body? So mental status is their level of consciousness, LOC. Some people use AVPU, alert, verbal, pain, are unresponsive. So I have mixed feelings about using the term alert, because in this sense, it doesn't necessarily mean that they are oriented. In this sense, when you're using AVPU, that just means they're conscious, because they can be conscious and confused or something like that. So just make sure if they are confused, you say, well, they're alert but they're confused. Verbal meaning that they're basically their eyes are closed and stuff, but they will respond to you when you talk to them. Pain is they don't listen to your voice or anything like that, but if you like pinch their shoulder or something, they respond to it. And then unresponsive, or just unconscious or whatever, just no response out of them at all. So that'll be like when you give them a sternum rub, nothing. You yell at them, nothing. They just are completely unresponsive. So when we refer to baseline vital signs, so that's the very first set of vital signs we take when we're on scene, and that'll be our baseline. And then we need to trend to the vital signs. So we take multiple sets over time to check for changes, things like that. So if you're doing that, you may be able to catch, if the patient is deteriorating or things like that. Respiration. So how are they breathing, and how many times a minute are they breathing? Are they adequate? So is it deep enough? Listening to lung sounds, do you hear wheezing or stridor, or how hard do they have to work to breathe? Are they tripoding? We talked about that position earlier. Are their intercostal muscles, the muscles in their ribs, retracting? What about the muscles in their neck? Are those retracting? Are they struggling to breathe? Is it noisy breathing? Look for things like that. So when we go to count, and I'm sure you guys have heard this trick before, but as soon as you tell someone to hold still, I'm going to count your respirations, they start consciously thinking about breathing, and that's going to change their respiratory rate, whether they think it will or not. So the best thing to do is say, hey, I'm going to take your pulse if that's okay. Take their wrist and set it on their stomach or their upper abdomen, and then count their respirations for 30 seconds. And that way they think you're just taking their pulse, so they shouldn't alter their breathing at all. So you can count it in how many breaths they take in 15 seconds or 30 seconds. If it's 15, times it by 4. If it's 30, times it by 2, and that'll give you how many times they're breathing a minute. And then make sure you document the rate. See here, they're kind of tricking the patient into counting their respirations as well as taking their pulse. So the pulse, knowing what their heart rate is doing, gives us, lets us know how their circulatory system is operating. So if their pulse is good, that indicates, okay, they're getting blood around to the body, which hopefully means they're getting gas exchange where it needs to be. And maybe something else is going on. So a central pulse would be your carotid up in your neck or your femoral, which is kind of like in your groin area. Then your peripheral pulses will be your brachial and the bicep, and your radial and your pedal pulse, or top of your foot. Just like respirations, we need to check the rate, but also the strength and the rhythm. Is it regular? Is it irregular? Check if they're responsive, don't go up and grab their throat. Check their radial pulse. If they're unresponsive, go ahead and check their carotid. But also remember this, so if they're unresponsive, check their carotid pulse. But I always try to check their radial as well, because they may have a carotid pulse, but they may not have a radial pulse. And that can mean there's a circulatory problem, or their pressure is just not high enough to get, to your peripheral pulses. So normal heart rate for an adult is 60 to 100 beats per minute. And that'll probably almost for sure be a test question. Any heart rate over 100 is considered tachycardic, tachy meaning fast. Anything below 60 for an adult is considered bradycardic, which is too slow. If it's like a kid we talked about before, if they're under the age of 1, check their pulse in the brachial artery in the bicep. Cap refill. So this is a great way to check circulation for peds especially. So you pinch the tip of the finger or your fingernail, and you notice that kind of your skin turns white. Well, how fast it turns red again is your capillary refill time. And we want it 2 seconds or less. So we want it 0 seconds, 1 second, or 2 seconds, basically, right? So be careful when you're answering test questions about this, because maybe one of the answers says that cap refill time is increased. And when you hear increase, a lot of people think, oh, that sounds good. It's cap refill. We want it to increase, right? We want the speed of it to increase, but the time it takes to do it, we want to decrease, because the lower the better for that. Okay. So cap refill, we want a decreased cap refill time is better, because that means it's less than 2 seconds. I hope that's not confusing, but if it is, just let me know and we can talk about it. So quickly release the pressure, observe color return to the fingernail bed, and then document your findings. Here's a picture of them doing it. Blood pressure. So this is the measure of pressure against the walls of your arteries. So your systolic, the top number, is how much pressure is in your arteries when your heart has contracted. The diastolic, the lower number, that's how much pressure is in there when your heart's relaxed. So 120 over 80 is considered normal. No one will ever really be that. But take several readings, meaning to trend it. If the patient's unstable, we do it every 5 minutes. If they're stable, we do it every 15 minutes. If their systolic is above 140, that's considered high blood pressure. Anything above 120 to 140 is kind of borderline. It just depends on the patient. Auscultation, a fancy word for saying listening. So we want to listen to the internal sounds of the body with a stethoscope. Really, the only thing we need to worry about is the EMR is the lung sounds. Have them sit or lie down, remove clothing on the arm, support the arm at the level of the heart, and select correct size of the blood pressure cuff. So when we do take a blood pressure, though, we do listen to the artery. So right here, the brachial pulse point is where we're going to hear that pulse that we're listening for when we are taking a blood pressure. So you put the blood pressure cuff on like so, and then you see how he's feeling for that brachial pulse point. Here's the range you want to be in, 120 to 180. So I'm sure you guys have all taken a blood pressure before. You put it on, you inflate it until you no longer hear the pulse at that point, or you can feel the radio while you're pumping it up, and as soon as that stops, then you slowly release the air out of the cuff while listening through your stethoscope at that brachial pulse point. And so when you hear the first heartbeat, whatever number that blood pressure gauge is at is your systolic. And then you keep slowly letting the air out until you no longer hear a pulse. And when you no longer hear a pulse, that number that the meter's at that point is your diastolic. Palpation. So palpation just means feeling basically. It's not a super accurate method for blood pressure. You might hear, someone say, "Oh, their blood pressure is like 100 over palp," meaning they got a systolic or something like that, but they couldn't get a diastolic and the pulse. I don't know. It's not accurate, and I don't like it when people do that. I would just prefer you keep trying to get a real blood pressure. Skin signs. So we mentioned color, temperature, and condition. So they can be pale, cyanotic, flushed, jaundiced. Jaundice is a yellow color, typically seen with people with liver failure. So pink, warm, and dry is what we want to see. Pale, cool, and moist is bad. Flushed, hot, and moist is not good. And flushed, hot, and dry is not good either. We want pink, warm, and dry. So if we run into people that have darker complexions than us, that can be a little difficult. So we can look at their oral mucosa, their conjunctiva near their eyes, their nail beds, and their palms to kind of get an idea of their circulation. Pupils. So just kind of look at their pupils, see what they look like, if there's any obvious injury. Make sure both pupils are the same size and make sure they're reacting to light. So they should constrict if you shine a light on them, and they should dilate when you block the light from them. There's an acronym for pupils. It's PERL, P-E-R-L. So pupils equal reactive to light. So here's some different sizes. So constricted, which is caused by some medications, dilated caused by other medications, or unequal pupils. Just be careful, like if you're out on a bright sunny day and you look at their eyes and they're pretty constricted, don't just assume, hey, oh my gosh, they must have done heroin or something. What I always do is I look around at my crew. Okay, what do their pupils look like in this situation or in this environment? And, because odds are they're all going to be constricted. If you're unsure, one thing you can do is have them close their eyes, cover their eyes with your hand for a minute to try to block out all light, and then say, okay, as soon as I move my hand, I want you to look right at me, and you can see, okay, was there any change after they were in the dark for a second? Did they dilate at all? Things like that. Could vital signs ever be considered unreliable? Oh yeah, for sure. Um, especially when people rely on their monitor to take a blood pressure, it's not always the most accurate. If it's cold outside, if the hands are cold, they're not circulating well, you're not going to get a good accurate pulse oximetry reading, things like that. So, you just have to always treat your patient and not the monitor, or is what we say, or, treat your patient, always look at how your patient is. If the vital signs don't really match up to how they're acting, then your vital signs are probably not very reliable.